Module 8, Maxillary Tuberosity, the surgical technique. In this module, I'm going to present for you several and different approaches of graft harvesting from the maxillary tuberosity. This is one of the most important modules of this course. The main goal here is to learn how to take bone from the maxillary tuberosity in the easiest and the simplest way possible. Let's go. I have two suggestions for you in order to go a little bit deeper on how to take bone from the donor site. First of all, the chapter 7 of the IDR book, that it's called the maxillary tuberosity as a donor site. In this chapter, we discuss about tissue biology and the surgical technique. And second, the chapter 11 of the implant therapy book. Here in this chapter, we discussed on the maxillary tuberosity as a soft and hard tissue graft donor site. And the second topic that I suggested for you to read is the types of graft harvest from the maxillary tuberosity. I'm going to talk to you about the instrument that we need to apply this technique, the chisel selection, how to do the chisel selection, how to select the right instrument to take bone from that donor area, and the technique itself. Many different ways to take bone from the maxillary tuberosity. Let's start talking about different types of graft to be harvested from the maxillary tuberosity. And let's start talk about the corticocancellous graft. And later on, I'm gonna talk to you about how to take a triple graft from the maxillary tuberosity. The corticocancellous graft can be used as a particulate bone for filling the gaps in intact sockets and also in compromised sockets, and as a block bone for the reconstruction of bone defects in compromised sockets. Here you can see a sample of corticocancellous graft that was harvested from the maxillary tuberosity. We insert this graft inside the container, and here you can see all you need to promote a faster and more effective bone graft incorporation. We have here bone and we have blood. This is all you need. So, as soon as you take bone from the maxillary tuberosity, we reshape the graft according to the defect size and width using a rounder in order to cut the bone and to match the bone according to the defect configuration. We may match the graft in height and width, and the graft has to be introduced underneath the soft tissue, and this graft is gonna be stabilized by juxtaposition, by adaptation in the remaining bone. Here you can see that we are inserting the graft underneath the soft tissue with the cortex turned toward the soft tissue and the marrow portion to the implant body. And after we insert the graft, the corticocancellous graft, and after we fill the gaps, you can clearly see here the corticocancellous block graft and the particulate bone graft. And how about the instruments to be used to apply the IDR technique in your patient's mouth? Here you have all the instruments that you need in your daily practice to use this technique. You can see here the IDR chisels, the hammer, tweezers, the probe, mini levers, a traumatic forceps, a rounder, serrated curettes, all you need. But the question is, can we apply this technique without the right instruments developed for IDR? Of course not. There is a rule that you can obey. And one of the rules is to use the right instrument in order to take advantage of this bone to do the bone reconstruction in your patient's mouth. And here you can see the IDR kit. Inside this box, you have 6 chisels. These 6 chisels in 6, 8, and 10 millimeters wide. 3 of them are straight, and 3 of them are gauge-shaped. Inside this box, we also have a bone compactor made of titanium and a container to insert the graft as soon as the graft is gonna be taken from the maxillary tuberosity. Here you can see the 6 chisels, 6, 8, and 10 millimeters wide. But pay attention that these chisels have marks in every 1 millimeter and special marks in every 5, 10, and 15 millimeters length. It's because we need to know where we are when we go deep within the bone. Here you can see the 6 ones. In the left side we have the straight ones, 6, 8, and 10 millimeters, and the right side we have the curved ones, 6, 8, and 10 millimeters wide. Let's focus a little bit more in the curved one. And pay attention in the active part of this tool, the tip of this tool. When we see from the tip of this tool and we put some surface as a flat surface, exactly from one of the edges to another edge like this, you can see exactly the height of this active part of this tool. And how important it is, because we'll guide the thickness of the bone to be harvested from the donor site. But pay attention, number 6, 8, and 10 millimeters wide, the curved ones. And let's take a look at the height of this active part of this tool. In number 6, we have 2 millimeters height. Number 8, we have 3 millimeters height. And number 10, we have, again, 3 millimeters height. What does it mean? Remember, our target will be to take bone around 3 millimeters in thickness. If you intend to take 3 millimeters of bone in thickness, when we use number 8 and 10, the edges of this tool should be coincident with the outer portion of the tuberosity. When we use number 6, we need to go 1 millimeter deeper in order to take 3 millimeters in thickness. The main reason of doing that is to save time, because time consuming is very important. But not only that, we have to transfer the bone graft from the donor side to the receptor side as quick as possible. Take a look at this picture and pay attention that the edges of the chisel should be coincident with the outer portion of the graft, the lateral portion of the maxillary tuberosity. And we can also control the chisel's depth and the length when we see these laser marks in both sides, in the front, in the back of this tool. All of them, the straight one and the curved one, have these special marks. Let's follow this video. Here we did a vertical release incision plus a perpendicular incision close to the gingival margin. This procedure will facilitate the suture at the end of this procedure. And we raise the flap using the multi-elevator, a 2-4 multi-elevator. After the flap was completely reflected, we check again the amount of bone available that we have already checked on the CBCT scan. And we use a periodontal probe in order to do that. The chisel was inserted 2 millimeters behind the second molar. And we introduced these chisels according to the length, the required length. After going till the planned length, the bone was fractured. And here we are releasing the bone from the donor area. And you can see here a corticocancellous block bone. And pay attention, not only the cortical layer, but also the marrow bone, the cancellous bone. And here you can see the 3 millimeters in thickness. This thickness will match exactly what we are looking for, the 3 millimeters of gap at the buccal aspect. So the depth of the curved chisel will provide the thickness of the graft removed. And how about the chisel selection? How to select the appropriate chisel? It depends on the mouth opening, and second, the required amount of bone. And remember that these chisels are straight or curved, and all of them are millimeter. And this is the rule that we use to select the right chisel. We always add 2 millimeters in width. If we have, for example, this case, this is the extension of the bone defect and the mesial-distal aspect, and we measure this distance. If we have, for example, 8 millimeters width, we are going to add 2 millimeters more. So the chisel to be selected would be number 10. And here you can see all of them, straight and flat, number 6, number 8, and number 10. That's the way that we select the chisels in the real life. Here, pay attention that we have in the mesial-distal aspect around 5 millimeters. So we can consider a pair number, 6 millimeters. So the chisel to be selected here will be number 8. Here, another example. Pay attention to this short video. We have around 6 millimeters, and we always measure in the most coronal part of the defect, not in the middle third, nor in the apical third. The coronal part of the defect will be our reference. One more example. We are evaluating through periodontal probe the width of the defect in the mesial-distal aspect. And here we have around 6, so the chisel to be selected will be number 8. Our first preference is always the curved one, but there are many reasons of using a straight one. During my speech, I'm gonna discuss with you the use of the straight one. Let's take a look at this sequence. First of all, we need to evaluate the extension of the defect, the configuration of the bone defect. That's the tool that I recommend you to use. We can do 3 marks. One of the marks is gonna be placed exactly at the gingival zenith, and 2 more marks at the mesial and the distal aspect. In this right lateral incisor, the patient lost completely the buccal wall. And we did here the simulation of the bone defect using blood clot from the socket in order to do that. And we check, after we did this drawing in the outer portion of the soft tissue, we are going to do here a double check, just to realize if we did right in the first exercise. After this graft is matching the anatomical contour of the defect, that's the right time to do the first checking. And we introduce the graft in the inner part of the soft tissue. This is the second exercise that we should pay attention to check the bone graft adaptation and stabilization using a tweezers. Another example. Here we have already performed in the outer portion of soft tissue the drawing of the defect using blood from the socket. This is the extension and the configuration of the defect. And we superimpose the graft as soon as we harvest the graft from the maxillary tuberosity. And we have to pay attention in this graft, in the width, the length, and the thickness should be coincident with the gap width. When what's missing here? It's missing to do the anatomical contour in the coronal part of the graft that should match the outline of the gingival margin. Now it's ready to be inserted and to leave this graft in the receptor site. From now on, let's focus on the technique itself. And I'm going to share with you different approaches of taking bone from the maxillary tuberosity. Let's start talking on the most useful incision to take bone from the maxillary tuberosity, the incision over the ridge crest. This is a very simple way to take bone from the maxillary tuberosity. And we do a posterior anterior crestal incision touching the crestal bone plus an intracircular incision. And we have to know where the bone is, because sometimes we can reflect the flap to the buccal and the palatal side. But if you intend to take bone and the bone is enough from the buccal side, it's not necessary to reflect the flap to the palatal aspect. This is what we did here. We just raised the flap to the buccal side and the bone was taken using chisels. And pay attention to the corticocancellous graft as soon as it